All right. I think we have a microphone to go around. We have a good amount of time for discussion. And I'd like to begin with, I asked you to think about the discussion questions that were after all of these presentations. So now if you look at your program, if you didn't already, you'll notice that those are all the same question. Essentially, how does this example fit with the model that we began with of how do you deal with the mismatches between population need, demand for health professionals, right? There's a mismatch there. Demand and supply, potential mismatch there, and then supply and health education. And these are all very different approaches that are addressing different kinds of market failures and are answering those market failures in different sorts of ways. So I'd be interested in whoever would like to kind of kick off the conversation about that. And if nobody volunteers, then our panelists will, I'm sure, have comments as well. But yeah, is the microphone? There's the mic.
Mine's not a kick off the conversation, a question specifically though. Rick, what do you attribute the nearly 50% female as a change in the demographics for the
I think that as we look back, it was pretty consistent with the women's movement. That when I started dental school in 1973, it was about 10% women, and then just the growth of the women's movement, it was almost linear, and then it just started to level off, and I think that it is. I think that for this generation of millennials that over recent years, that dentistry provides an opportunity for not just women, but men who want some balance to their lives. Dentistry is one that you can control your hours for the most part. There's not a lot of call. What's remarkable to many of us is that the average number of hours that a dentist works per week is only 34 or 35. And so, what can I say? But over the lifetime of, like everything, men come out of dental school and work 60 hours a week and then start to trail off over time. Women come in taking care of family issues and then increase, and by the end, in the 60 to 70-year-old cohort, they're working more than the men who began. It's kind of ironic in a way, but that's the way it is.
Yeah. So I'll point out that the first two models that were discussed were very heavily government-supported education models, whereas dental education in the United States is very heavily financed by the individual paying tuition.
Yes.
But there were some highlighted still maybe market failures that exist in the system with respect to unmet needs among populations. So I'm trying to feed you some areas to think about but then again, if the dentist kind of lifestyle, as it were, is probably very enviable compared to some of the physician work hours and expectations. So where do we see different opportunity, where do we see continuing market failures or risks or issues with these different strategies towards financing?
Comment on a couple of things. First of all, for dentistry, just to have that contrast of example, not as much is funded by insurance. People who can afford to pay. You charge what you need to cover your insurance and your costs and make a decent living. That's not as easily the case in the other health professions, in that you have, for example, Medicare and Medicaid controls over reimbursements. You can't necessarily decide how much you're going to make in some of the other health professions. And then the flip side of that is that you have Medicare, Medicaid, and you have community health. So you have access for low-income people in the professions that aren't able to as easily pay back their loans quickly and so on, and you have less access in dentistry. And I do know in public health dentistry, there's a lot of effort to try to get more out to the community, and particularly pediatric dentistry prevention more out to the community. But I think it's interesting that you have these contrasts, in a sense, mirror images that are quite different.
One of the interesting, overlays to all of this is that in the United States, different from most of the other countries that we talk about here, in the United States, the federal government doesn't control healthcare financing and education financing. And so in most other countries, you can, because you control the education financing, you can educate to what is going to be financed. But we don't do that, even at the state level. And that's why I think that what we saw in the ACA and the impact of the Medicaid funding for children and this just dramatic drop in unfilled unfilled teeth that had decay has been just a big surprise to all of us, including the fact that the dentists were taking care of these kids. It's been a remarkable success.
Good, you're.
Oh, that one, thanks. Yeah, I'm on the program to say more about the other countries tomorrow, but this may be, for one element that I will expand on tomorrow, a good point in time. We hear a lot about the need, kind of almost implicit, because to quantitatively define that specifically, for example, for pediatric dentistry or for clinical pharmacology, etc., is pretty difficult. Demand is to a large extent there, but the explicit financing reasoning is very nice, many of the stories that we hear, but the title of the workshop is Future Financing. It's not the reform that we do. It's not how nice we all want it to be. You're asking for the financing, right? Now, in all three presentations, financing is kind of taken as a given. And it's either a given in most of the presentation from the public sector or to some extent in revenue from the private sector. And the assumption is that it will continue. And it won't. There's no way. This last discussion was explicitly about the United States. And then you did make a reference to some other countries. United States will have 19% of total GNP spent on healthcare. The United States' total economy, proportionally in the world economy, is dramatically reducing. It's not growing. It's going down. Right? Public money will go down proportionally, and private money will go down proportionally. So if you simply think that 19% of GNP in the United States will go to 25%, keep on dreaming, right? It's very nice, but there's no way. Similarly, the £100 million under the NHS in the UK, forget it. This is a complete dream. With Brexit, over the next 5 years or 10 years, the UK GNP will actually probably contract. See? The NHS is under enormous pressure to reduce its budgets, not increase it, regardless of the ideology of the total population. But the Treasury in London has all kind of big red crosses all over its budget. So I suggest that, and I will, as I said, expand tomorrow about it, but I suggest that the discussions also in the working groups go beyond the nice statements of what we nicely do in this medical school or that medical school in this program, and look how nice we're working on reform here and there. But look at the money. Look where the money will come from. It won't continue as it is. I assure you that. There's absolutely no way that the United States, even if the majority of the population would vote for it, that Treasury here will be, and the private sector in the United States, 8.5% and almost 11% private sector, that will continue. They will slash it. So you have to start thinking of, okay, I have some public money, I have some private money, I have some money from insurance and from tuition, etc. I'm going to run short on this. Where will the rest of the money for the objectives that I'm setting myself for the next 10 or 15 years, where will they actually come from?
So I think we have a challenge question that I'd like our panelists to respond to. Is there a discussion about the sustainability of this? Is this something that's being ignored for the short term and, but it's an issue? Or is there a sustainability plan? So why don't we start with the East Cape example?
No, thank you. Definitely from a South African point of view, there is ongoing discussion, and I think it has been going on for the past 10 years. And when you look the period spent and where we are now, students starting to engage to saying there's a need for a relook at how general we fund higher education, because higher education and funding health professional education is not going to be separated. It's part of that particular pool. So there is ongoing discussion. The issue, is that from an economic point of view, the economy, for instance, in our country is not growing, and the cake is not increasing, and therefore we have to look at options. What is obvious is that we are not going to have additional funding, within the current fiscus. But there are two arguments I think that are emerging. One is that we need to look at the efficiency of spending. At the moment, we don't believe that we are planning and forecasting enough to be able to be close to how we are really delivering. The second part, is that we are moving in the right direction. We've created new departments, but as we're creating new departments, there are coordination issues within those things in order to focus on clear mandates and where to spend and why we're spending in that. So we've got gaps there in our system, and I would want to also argue that what we are doing is not different from the rest of the African continent in terms of grappling with alignment of planning, coordination, and funding, of education generally. But there are signs of starting to say, if the pace that we've been relying on is restricted, why can't we engage other partners who benefit, from what we produce? At the moment, we've been relying a lot on the state, but private sector is a beneficiary in terms of the services. How do we draw them to partner with the state or to partner with the institutions in order to deliver what we are delivering? There are signs. The National Minister of Health started what we call Public Health Enhancement Fund, and one of the issues with the CEOs of the industry was how do we fund health professionals training. We will have some bursaries, a bit of money towards building capacity and starting off new medical schools. So those are the discussions that are taking place, but I think that debate needs to be broadened, and I think we need more private sector participation. But the private sector is faced by the same circumstances, and we're not in a state where they have got money to say, hey, we understand what you are coming up with. So we're all in the tight fix. It's going to depend on who prioritizes what in terms of the agenda. So I think those are some of the things. The shifting burden, to students and therefore graduates is going to cause problems. If you saw, say, as I was showing, that we are able to retain a significant number of our students in underserved areas, especially those that are inputting into our programs. The key challenge is going to be, if I come out with debt, I may have to look at somewhere else to go and work in order to get that debt. Now, the question that comes with that, that we are raising generally, with our government and private sector is that if we continue with the current arrangements of bursaries and loans, we need probably to look at, loans that are payable by service, so that by the time the kids are getting out, for underserved areas, at least we are able to relieve them of that burden so that they can go and make the choices that they are making. You can say it's an interventionistic thing that is dependent on availability of resources, but that is, what we are sitting with. And you heard me talking about grant funding. It's available, it is there. I genuinely do not believe that we are using it efficiently. I think even with that, we can squeeze a lot. If you look at tertiary services, what is available as an envelope, we tend to duplicate tertiary services everywhere across our region. And we need to look at where we need tertiary services in order to release money to go to lower levels of care. Now, we've got what we call health professions training and development grant. Somewhere else, I think the Western Cape, in South Africa, they targeted it at sort of level 2 regional services. With us, because of the nature of how we train, we've actually been using it at level 2 and below. But that is not in line with the policy, you see, and there's always that challenge that you're not using the money according to conditions attached, and therefore it can be recalled anytime or can be an audit query and all that. So those are the policy issues that would assist in terms of efficiency in the expenditure. That's right.
Yeah, hi. So some absolutely bang on points about the kind of global economic position. The story was meant to be about effective deployment of what public resource you've got, not one about thinking there's going to be more. So within we have a 5-year comprehensive spending review. The NHS has been given an 8 billion settlement, real terms, pretty small increase. And my organisation been given flat cash, so real terms reduction. But that first slide says we deploy it on some things that we probably don't need to because there isn't a market failure. And I really like the example of, this is a great example of not having a market failure. Debt funding is working for that bit. The failure here is demand. How do you get, who's buying the services for the kids with the caries? So I think that's what we're trying to explore, which is what mix of funding in what model and under what circumstances is right. And then your question is, well, do you get to deploy it or do other things get in the way? So I think that's the kind of area we're trying to explore. And that's what my example was trying to play out, which is there's a known need, you're able to act, but it has happened before. So, let's explore why haven't general practitioners created clinical pharmacist roles under the incentives and conditions of their payment? That's a demand. We could have done all the training you want. Doesn't matter if there's not a job. So I think what this model tries to do is to do the ABC of need, demand, and supply. I think that's really important. When people talk about shortages, it's often a demand shortage. There's a shortage of doctors versus need. There's no jobs. You produce that supply, it's not going to help. But everyone points at the supply end of the spectrum, which is, I get touch sensitive about it. So I think that's what we're trying to tease out here. And certainly in our breakout session, we'll be very honest about what works in public funded education and what hasn't. And maybe there are lessons about, therefore, what choices do we make? Whereas, debt funding may be absolutely fine if it's a definition of future earnings, and that's a fair deal. So.
I think in terms of financing of health professions education to begin with, I think, at least in the United States, the government has essentially already started to walk away. That at the state level, 25 years ago, which might have been 30% support to the operational budget of public institutions, has gone down to the 3 to 6% range now, and so that has walked away, and so tuition and fees have gone to replace that. And then the ways that students can pay for their education, the loans, interest rates have gone up. The time that you can allowed for deferment of the loans has diminished. I mean, in terms of the federal government being a banker and collecting interest on loans has been huge. So I think that from that perspective, the federal government has indeed and the state governments have walked away in big part already. I think that if the vision of the ACA is able to move forward, that especially in moving towards volume to value, that there will be that at least the cost curve bending might happen. We'll see. But that's going to be, somebody's going to be a loser in that, and it's going to be those practitioners essentially, and the systems, and either it's going to, a certain amount will be cutting out the fat to be able to be more to be more efficient and to push that. But everybody's going to have to take a cut to some degree in that regard, and those who are able to do it, perhaps the Kaisers and Geisingers and others that are able to do it more efficiently. But remember, a couple of things that we talk about is that 2012 was a milestone year in many ways, in that the majority of physicians in the United States became employees. The majority of babies in the United States that were born were not white, and the Affordable Care Act was affirmed by the Supreme Court. Though all three of those things really are resulting in milestone changes down the road. And so I think that that those, there at least are changes that are in the pipeline that I think are going to impact those and the sustainability. So from an economist's perspective, I think that we need to look at our assumptions as they are today, or from, I don't mean an economist's perspective, but from the perspective of what is going to happen. We have to think not just about the assumptions as they are today regarding health professions, education, and health care, but what are the changes that are in that pipeline and how might they impact as we go forward?
A patient person waiting back there. Is there a microphone?
I think I don't need it. No,
Yeah, you do, because there's a webcast. And
in developing countries where we don't have the constraints of the existing professional infrastructure that we do in the industrialized countries, we immediately turn to task shifting, to redefining roles based on the task that has to be delivered. Now, in the UK case, we see an interesting example of task shifting. I don't know where the BMA was in that development, but the question is, where are the points of resistance to aligning the financing more appropriately with the patient's needs and the scope of practice of the individual who's capable? And then we have the case of dentistry in the United States, which is the poster child for resistance to expanding task assignment appropriately to the needs of the patient in line with the availability of practitioners.
So the answer is, so this has been done with the Royal College of GPs and the GPC of the BMA. And it's because they get that there is no GP supply solution. They know that we should be working on primary care, and therefore they've become more open to that kind of plan B. And I think as long as you recognise this isn't about diminishing the profession or its role, and you talk about it respectfully about people doing working as a team, healthcare as a team sport, they've been really supportive. But part of that is born out of a situation in which they think the workload for their members is so great that they see it as a crisis from which change has been supported. So it is interesting that kind of behavioural economics thing about what's going on here, about what might have traditionally been a resistance to that kind of behaviour.
so I'm curious, thinking about that financing balance, has a net calculation been done of what the cost would be to prepare a GP from the get-go versus the cost of doing this add-on training for pharmacists who already exist and have already invested in the education, but then you're paying part of their salary? Is there a sense of a break-even point?
Yeah, well, no, I mean, so the upside financially is just undisputable in terms of the model, but that wasn't the driver. I mean, perhaps it should have been, and they'd been interested. So, say we hadn't had supply constraints, would we have done the GP thing? The answer is almost certainly. You know, so we should explore that. Why, if that would have happened, would we have spent more money for potentially worse outcome? You know. So I think that's what we're in the room to kind of just check out.
Yeah, Deborah.
Wait a minute, I had the mute button on. That all that works. I had a question. There recently have been conversations with respect to undergraduate education that as more students become employees, it's beneficial to the academic institution and to the graduates then burden. What are the implications, if any, do you think, with that approach in health professions education?
So that as more become employees, that
So as more, in the undergraduate, the undersecretary was speaking the other day, and he was
Right.
talking about how increasingly more those students that are going for bachelor's education
Right.
are becoming employees of the academic institution while they're students.
Right.
And that they're seeing a benefit to both the institution and the
Yeah.
student.
And Arizona, so
Yes.
Arizona State University, whatever, a third of their students are employees of the university, one way or the other. I think some of us used to work study kinds of opportunity, but that there's so they have, there's a development, especially from a technology perspective, of call centers and all these other kinds of things at universities that moving perhaps back the pendulum back to, well, if we have all of these jobs, why don't we give them to the students who are part of our institution right now? And there seems to be things that we've heard in a variety of ways from college presidents and others that's ongoing. The other thing is the age-old conversation: should it take 4 years after college to get an MD degree, to get a dental degree, so on? I mean, do you need to take biochemistry again? Do you need to, is there a way to accelerate that? Certainly the Association of Osteopathic Medical Colleges went through this whole Blue Ribbon Commission about how to condense perhaps the medical school curriculum. But things that we've been looking at is how could you look at the college dental school years as one continuous curriculum and try to blend it all together. I think that's another. You shouldn't have to wait 8 years for many of these kinds of. I mean, no matter what kind of profession you're talking about, but can't we reduce the number of years? And even in the UK, the conversation of going from 6 years to 5 years and so on and so forth. I think that those are the kinds of things we also need to look at, just to get people one more year, not just getting more people at least into the system, but also a year more of professional life and another year of earnings.
I have permission to take one more, and then our time is up.
Hello, my name is Sabrina Mikhail. I work for the World Health Organization, and I'm pleased to be here. Thank you for putting together this workshop, very interesting. But looking at the health professionals crisis that we have worldwide, and the comment that you just made about looking at how the situation with health professional education will be in the future, what is the role of models, for example, interprofessional education on the financing? Because these are models that perhaps could use the resources more efficiently, other than having a great impact on the practice. Once these professionals start to work, they will already have experience doing it together. I would like to hear a little bit from you about that aspect. Thank you.
I'm no expert, but I think it's a really interesting proposition. So we had some experience of doing interprofessional education, postgraduate and in service with the non-medical endoscopists and the endoscopy teams, and it was hugely successful. But I've also seen the case for saying, but if we learn together earlier, then perhaps some of these kind of barriers to team working might be removed. And I've not yet seen compelling evidence one way or the other. You know, it feels like a really attractive proposition, but is the strength in it postgraduate or undergraduate or both, or is it conditional? So I'm no expert. What I recognise is that at the moment some of the financing would just gets in the way of us even trying it. You know, so we haven't even been able to kind of observe what benefit can we get if we remove the financing issues that prevent interprofessional education. When do we see the benefit? But I think it is important that we kind of think about how teams train together, you know, multidisciplinary, multi-professional teams, in terms of specialist skills and postgraduate stuff versus that kind of entry-level professional training.
Now, I think in our case, the observation was that with the shrinking budgets, it's something that we need to look at. But as the university had already, you know, started multidisciplinarity in terms of that. But as we go out away from the center, we've picked that there's a lot that we can share in terms of resources, even beyond the university, because there are other. In the platform, you'll find that there will be a nursing college that has students that are there. You'll find that we have got our physician assistance training that is there. And they've got medical students there, health promotion students that are there. And we said we would want to consider this and do it properly. At the moment, it's more of an accident in doing it, you know, than a well-concerted, well-conceptualized interprofessional learning environment. But I think when we're looking at it as the resources deployed, there is a way, you know, it will assist in terms of cost sharing and reducing unnecessary expenditure, you know, as we duplicate a lot of things now.
Just one additional comment that technology, I think, is going to change so much of this, and the evidence that we are seeing begins with although MOOCs and other things haven't done so well, especially in the States, they have done well, much better in a global perspective. Just the issue of cultural sensitivity and cultural appropriateness are the issues, but I think that they are doing well in that way, and they probably show much promise for the future.
We thank the panelists for their presentations. Yeah.